Hello viewers, Namaste. I'm Dr. Kishore Alapati, one of the consultant colorectal surgeons at Apollo Hospital, Jubilee Hills. Today we are here with our senior consultant from the Department of Colorectal Surgery at Apollo Hospital, Jubilee Hills to discuss about Crohn's disease, what are the causes, symptoms, how we identify Crohn's disease, how we treat it, whether it is a medical treatment or surgical treatment, and so on and so forth. So welcome, Dr. Mathai.
Thank you.
So to start off with, what is Crohn's disease?
Crohn's disease is an inflammation of the intestine and can actually affect any part of the gut from the mouth down to the anus. Most commonly, the small intestine and the large intestine are affected, but it can affect all of the intestine or only parts of it.
So anytime we come across this discussion of Crohn's disease, there is always, patients would come up and ask us, what is inflammatory bowel disease and what is Crohn's disease, and is there anything else other than Crohn's disease?
Well, nobody really knows the true cause of Crohn's, though it's considered to be an autoimmune and genetic disease. But we also think that there's a certain amount of environmental factors and diet that is involved with it, but nobody is totally sure. We do know how to treat it, but the exact causative reason is unknown.
Right. And again, Crohn's disease, even when we were going through our medical schools and training, is more of a Western disease. It was more of a Western disease, and in India, classically, most of these signs or symptoms that are being identified or stamped as Crohn's disease were back in those days considered as tuberculosis. Now, is that still the case, or do you still think that the chances of or incidence of Crohn's disease is less in India, or are we matching up with the Western population?
Well, it's definitely less in India as compared to the West, but we are not seeing as much tuberculosis now as we were seeing then. When I say then, I mean in the 80s and early 90s. And definitely over the last 2 decades, the incidence of Crohn's disease in India has increased. So we still do have in India a lot of infective or viral and bacterial infections of the gut. But Crohn's is definitely on the rise.
On the rise, yeah. And another common myth that's there when patients come to talk about Crohn's disease is, what is IBS as irritable bowel syndrome, and what is IBD as inflammatory bowel disease? Is there any difference, or both are more or less the same?
Well, they are totally different, though the symptoms can mimic each other. And that is why if a patient comes with abdominal pain, bloating, diarrheas, you need to rule out an inflammatory bowel disease. It may just be an IBS, which is aggravated by anxiety and other things, but IBD really needs to be ruled out in those patients.
So you mean to say that when they come with the specific complaints, then you thoroughly investigate the small intestine and the large intestine, and if they are found to be completely normal, meaning no evidence of inflammation, then you can stamp those patients as
IBS.
IBS.
Yes.
Irritable bowel syndrome.
So irritable bowel syndrome is, once we have investigated them thoroughly, all the tests are negative, then we would call them IBS.
IBS, right. But whereas IBD is something that would definitely require treatment depending on whether it is a Crohn's disease or ulcerative colitis.
Yes. Yes.
Okay. So then coming to that, what would be the most common signs and symptoms of, for someone to be called as IBS or IBD, for them to come for evaluation?
Well, the commonest in both IBS and IBD are generally abdominal pain, bloating, and a change in bowel habits, either of a diarrhea, usually of a diarrhea. But the IBD patients would, in addition, generally have a loss of weight, a little loss of appetite, a lot more systemic symptoms as compared to those with IBS.
Right. So the IBD patients, would you say, generally look a little bit more sicker?
Yes, they would look a little more sicker. If you're looking at them in the teenage group, their growth would look a little stunted, that kind of.
Right, right. So the Crohn's disease is something that is more commonly seen in the teenagers?
Well, the common age group is 15 to 35,
Okay.
which is the main age group.
Okay, okay. Then once they come up with the symptoms and signs, what are the good ways of proceeding with diagnosis, or how do you diagnose that they do have Crohn's disease or not?
Well, it's best to have a biopsy proof that this is Crohn's disease, because once you label somebody as Crohn's disease, you're looking at lifelong treatment. And before starting them on treatment, you would want to be 100% sure that you're not dealing with an infective colitis or something else other than an IBD. So always the initial management in Crohn's is medical.
Medical treatment. Yes. Right. So one word that you've used is someone is stamped as a lifelong disease. So Crohn's disease is indeed a lifelong disease?
It is indeed a lifelong disease.
So once diagnosed with Crohn's disease, that patient is stamped as Crohn's patient for the rest of his life?
For the rest of his life, they are put on some degree of immunosuppression.
Right. So what's more important here is to make sure that those patients, like be it for blood sugar control, or be it for blood pressure control, how someone is taking medications on a regular basis, even if the blood sugars or blood pressures are under control. To keep the Crohn's disease under control, medications need to be continued for the rest of their life, and those patients definitely need to be followed up by either a colorectal surgeon or a medical gastroenterologist to make sure that there are no flare-ups in the Crohn's disease.
Right? The thing with the Crohn's is that you can have quiescent periods and flare-ups.
Right.
So they need to be on follow-up throughout.
Right.
And if they have a flare-up, then you need to increase medication, and when they are controlled, you bring your medication down to a baseline level.
So is it a threat if a patient will have frequent flare-ups, meaning they are not taking their medications, or they are complacent about their medications and they take it easy, forget taking their medications, work pressures or whatever it is, and they're frequently going through flare-ups? Will that cause any trouble?
It will cause trouble, because more the inflammations that happen, then in the bowel you can get stricturing, you can get bleeding, and there are other issues that come up with that.
Okay. So they definitely would end up with a much more complicated disease
Yes.
than if it is under control. So controlling the flare-ups is also equally important. So having said that, what are the treatment options? So when patients come by, do they go through any kind of medical treatment for a period of time, or do they immediately require surgical treatment? So in cases like that, what would you recommend in regards to medical treatment for those patients?
Well, there are two approaches to the medical treatment. One is the step-up approach, and the other is the step-down approach, where in the step-up approach we start with medications, milder medications first, and if they are not controlling the disease, go up. Okay. Or in the step-down approach, give them the highest medication first to try and heal the mucosa, which is supposedly decreases the problem with them.
Okay. Right. So medical treatment definitely is the way to go.
Is the way to go.
Is the way to go. And even so, after you've started on the whether it's a step up or a step down approach that you've said, you would expect the disease to be under control within a certain period of time, and if it is not, that is when the surgery is indicated?
Well, the surgery is really done for the complications of Crohn's. And very rarely does a patient who is undiagnosed as Crohn's come with a surgical emergency, which later turns out to be Crohn's. Usually they have been diagnosed, have been on treatments for some point of time, and then come with a complication which then needs to be dealt with surgically.
Okay. So what are the surgical, so you said the chances of these Crohn's patients requiring surgery are if they're bleeding, number one.
Yes.
A stricture, would you explain to us what is a stricture?
Well, repeated infections in the bowel cause the intestine to narrow down, and the narrowing down prevents the food from going through. They tend to have recurrent episodes of abdominal pain, vomiting. Okay. They're not able to digest their food, so they start losing weight, and Those are the things that happen. The other problem, of course, is when they develop a perforation,
Right.
when there's a hole in the intestine from the Crohn's.
Right. So that is an emergency.
That's an emergency
scenario. Emergency scenario. So when patients do come up with this, episodes of bleeding or episodes of stricture, as in narrowing of the intestine, what are the surgical options that are available for them?
Well, I think when we look at strictures, we have to look at two factors. Whether it is an inflammatory stricture or the disease there is burnt out and it's a fibrotic stricture. If it's a fibrotic stricture, then almost definitely surgery is indicated. If it's an inflammatory stricture, you may be able to try a period of steroids or to see whether you can get that inflammation down and open it up. But fibrotic strictures definitely need some sort of surgery to remove that piece of bowel and to rejoin it.
Now, so after the surgery is done, will those patients need to continue with the medications?
Again, two schools of thought on this, but I would tend to continue them on medication because otherwise we would have to repeat multiple biopsies and see that there is no evidence of Crohn's. Very rarely does it remain in a single point only.
Okay. So like you said in the beginning, it's a disease of the entire length of the intestine, so it's better to be on some kind of medications and be on a follow-up with their respected medical gastroenterologists or the colorectal surgeons. Now, these surgeries, are they more or less the same type that would require for the small intestine and the large intestine, or is there any difference between Crohn's of small intestine and large intestine?
Well, the surgeries in general for any part of the intestine would be to resect a segment of the intestine.
Right.
Now, in Crohn's, you need to resect as little as possible.
Okay.
Because you never know when a patient may get a stricture again and more bowel needs to be resected. And if you resect too much bowel, then they end up with a short bowel syndrome, which is another issue.
Right. So in surgery, being as conservative as possible is definitely the most important thing. So in regards to surgery to the large intestine, when you come across through a stricture or bleeding, do you think it's still the same as removing a section of the intestine and be able to reattach the ends back together?
Well, technically yes, but again your resection in the large intestine will be a limited resection. You are not looking at a resection like you do for malignancy. Though of course malignancy can occur in Crohn's,
right,
but then that depends on the length of time that somebody has had Crohn's. So if you've had it more than 10 years, your percentage is about 3%. If you've had it more than 30 years, your percentage is about 10%.
One other big question most patients will have in their mind or would come up to ask is, what is the chances of them having to deal with a bag wherein, like a colostomy bag, or will we be able to, or will you be able to remove the section of the intestine where the narrowing is and be able to reattach them back together?
Well, in the vast majority of Crohn's, we will be able to remove a segment and reattach back together. We may need a temporary bag depending on whether we do it in an emergency for a perforation or some of those other factors. But in the vast majority, we will restore the continuity of the intestine.
So the chances of
a permanent bag are less.
Right. So rest assured, that is something that is definitely good news for patients who are suffering with Crohn's disease, and they were told that they would require a permanent bag when they go in for an operation like this. So one other very important aspect, I think, is younger patients or some patients, whether it is males or females, developing these fistulas in the anal area and correlation of that to the Crohn's disease. Is that commonly seen? How do you treat them? I'll ask you one by one, but how commonly is that seen?
It's fairly common. It's not uncommon, if I can put it like that. It's not as common as having de novo fistulas, but we get a good number of Crohn's patients with fistulas. And treatment per se in perianal disease is to get rid of the sepsis and try and prevent further sepsis from happening. So, to prevent further sepsis from happening, we need to put cetons through those fistulas so that abscesses don't reform, so that the medical treatment with biologicals can go on.
The minor detail that you're saying is that because these patients tend to be on medications which will suppress their immune system, sepsis, having an infection or a source of sepsis is detriment, and so you would want to get rid of that infection so that they can continue on their medications. Okay, all right. The perineal fistulas. In females, does it make it even more complicated, or not much difference between males and females?
Well, with the females, we tend to see sometimes them developing rectovaginal fistulas, which then becomes an issue.
Okay.
With the, but
right. So rectovaginal fistula is where the stool
starts coming out through the vagina.
Now, in Crohn's patients with anal fistula and or rectovaginal fistula, medical treatment still has a role, or how well will they heal with medical treatment?
Some will heal with medical treatment, but many will not. But the problem is that surgical treatment also has a fairly high failure rate.
Right.
But
so,
sometimes you're not left with much of an option.
So you try your best to treat them with medications, and if the medicines are not allowing it to get back to normal, that's when surgical intervention is required in those patients. So when we talked about these surgical procedures for Crohn's disease, Dr. Mathai, is it always open surgery? Do you think you can do them in lesser invasive techniques or technologies? What is the difference in recovery between open surgeries and laparoscopic surgeries?
Almost always now we do it laparoscopically if possible.
Okay.
And like I said, you try and save as much intestine as possible. So when you don't have a choice, you resect. When you have a choice and you feel that you may get away without actually doing a resection, you may have to do something known as a stricturoplasty in them. But all of it can be done laparoscopically.
So minimally invasive surgery where the recovery is much more easier. Recovery much more easier or quicker, like you heard Dr. Mathai say, is important in these patients because again, these patients definitely would require some kind of immune suppression treatment, and so we would want those wounds to heal as quickly as possible so that those patients would be able to get back onto their medications as soon as possible, so that the chances of those flare-ups will not be there, frequent flare-ups, and that is how you keep the disease under control. So in regards to diagnosis, one other thing I wanted to mention to you is, apart from colonoscopy, are there any other investigation modalities like looking into the small intestine, whether with a scope or a CT scan or an MRI scan or a PET scan? What are your thoughts on that?
Well, I think you should definitely look into the rest of the intestine because you need to know how much of the intestine is involved. MR enterography or CT enterography are good modalities to use as far as this goes. One of the advantages with MR enterography is to differentiate when patient has strictures, whether it's active inflammation or whether it's a fibrotic stricture. So whether you will treat that with medication or think primarily of surgery in it.
Okay. So MRI scan, which is a different scan than the routine MRI.
The enterography.
Enterography plays a bigger role compared to the CT scan.
Yes.
CT scan. Is there any way we will be able to look into the small intestine as in a scopy?
Yes, we can.
Yeah.
Yes, we can, and that's a good thing because then we can take biopsies as well.
Okay.
So small bowel scopy is a very good method. And if we can get biopsy those areas, that is of course the gold standard.
Right. So once after the treatment is done, be it the medical treatment or surgical treatment, How often will these patients require to go through this process of CT scans or MRI scans or colonoscopies to
Well,
assess
we
the disease?
generally monitor them with the blood levels of various things.
Okay.
And not too much of, unless they are symptomatic, we don't really keep imaging them.
Okay. But to get an all-rounded assessment of
We
the
would
disease,
do that right in the beginning, isn't
In the
it, before we start.
right. Or would you do all of those when there are flare-ups?
When there are flare-ups, yes.
When there are flare-ups. So it's an all-rounded evaluation of MRI scan along with endoscopy to see where
Absolutely.
the disease is. So viewers, thank you so much for participating in the live discussion. I hope you have gained enough knowledge about Crohn's disease. And again, to summarize, Crohn's disease is a section of what we call an inflammatory bowel disease, which involves any part of the intestine from the mouth to the anus. Once diagnosed by either an endoscopy, as Dr. Mathai said, or MRI scanning, and once we have a biopsy that is proven, those patients are given the diagnosis of Crohn's disease for the rest of their life, and they definitely need to be on a regular follow-up, at least every 6-month period, with their medical gastroenterologists or colorectal surgeons in their local area. Try to be as compliant with your medications as possible, otherwise you will definitely end up with flare-ups, and the flare-ups are the ones that will take you to a person like him as a colorectal surgeon, who would advise you for a surgery. And as he said in his golden words, you would want to keep the surgeries to as less number as possible, otherwise removing more and more length of the small intestine will cause what's mentioned as short bowel syndrome. So be in a regular follow-up, and rest assured the chances of requiring a colostomy is very rare. Most of the times they will be able to put your intestines back together, and then your life gets back to normal. So be sure and be compliant with your medications and be compliant with your doctor's appointments. Have a wonderful day.
Thank you.